You're listening to Addiction Medicine Beyond the Abstract, the official podcast of the Journal of Addiction Medicine. If this is your first time listening, thanks for coming. Addiction Medicine Beyond the Abstract is produced for your enjoyment and is focused on the latest journal-published research and science in the field of addiction medicine. Remember to add us to your favorites in iTunes. You can also follow us on Twitter. at ASAMorg and Facebook. Now, let's go beyond the abstract.
Welcome to Addiction Medicine Beyond the Abstract. I'm your host, Dr. Sean McNeil, and today we're joined by Dr. Kathleen Carroll. She's the Albert E. Kent Professor of Psychiatry at Yale University School of Medicine. So welcome to the podcast, Dr. Carroll. It's a pleasure to have you here. So let's get started by talking about your background in addictions, just discussing your interest in the treatment of addiction and the research of addiction.
I've always been, I'm a clinical psychologist and actually began my work in this in graduate school at the University of Minnesota. And then I came to Yale to do my internship, and I've been there ever since studying addiction. I still have my first job as it is. And so, I just think there's so many interesting questions and there's such, still such need. We've come so far. When I started, there were, very few medications to treat substance use disorders. There were, nothing like manuals or empirically validated treatments. And so if you look at where we are now, it's really just extraordinary in terms of how much more we can offer people and the places we can treat people. And I think the issue now, as I started off at the age in Project Match and way early, and so the issue now at this point in my career is really trying to figure out how to get effective treatments to people who have substance use disorders most effectively. So that's kind of how my whole career has arced. I started from making manuals and trying to kind of systematize behavioral therapies so they could be studied effectively. And, we did that, try to, show how they could, be combined with medications when those were available. We did that. And now it's just trying to, kind of push these treatments out to people who can benefit from them.
All right. So why is it that these traditional SBIRT programs have been more successful in addressing the alcohol use as compared to other drug use?
It's a really good question. I think when people come into primary care with alcohol, it's sort of it's a very teachable moment, and if people are not sort of at the severe end, we've seen this in general where, motivational interviewing and other kind of brief interventions can really have a big effect. And, the treatment of drug abuse, especially when you get into the moderate to severe levels, it's just a lot harder. People usually need more intensive treatments, getting offers of medication when they're available, and more than a session or two. So I think that's something that we've seen over and over again. And, Dr. Sates and others has really commented on. So now if the screening and brief intervention isn't sufficient, then what do you do next? And it's usually the notion that you refer people to treatment. And so there's been a couple follow-up studies from the big SBIRT studies that showed that the rates of successful referral when people actually got treatment, even with pretty warm handoffs, as we call them, is really low. I was very surprised to see it tops out at maybe 20%. So there's really a lot of missed opportunities, and people who get lost in the shuffle or don't or won't go to specialty care or can't afford it. There's all kinds of barriers in the systems.
Okay. And you mentioned that some of the challenges to treatment are the long wait times, low motivation, the costs associated with these programs, and of course, and transportation issues. So do you feel that the computer-based interventions address these challenges?
Yeah, I mean, computers, we've been working with computer-based interventions for a long time now, and we started out doing this work like in the early 2000s and tried to study them systematically and to figure out what they could and they couldn't do. And, at first we just added it on to standard specialty care, and we saw that it taught people things and that seemed to be beneficial, and the uptake was really pretty good. And then as we went on, this was all in specialty care, we showed that these treatments were actually, pretty good. And, given with just really brief clinical monitoring, like, 10 minutes every week, just to make sure that level of care was still appropriate for the person. Our CBT for CBT did just as well as treatment as usual, as standard care. And so, when that happened, then when we found out it could, it was effective, it was safe monitoring, it lasted a long time. We really then moved to think about, well, this could really be used in a lot of different places, and that's where our work has been. I think in primary care, the staff now more than ever is just so busy, and it's hard to follow through on referrals. It's expensive to have specialty staff there all the time. So having this as an alternative, I think this may be one of the best matches of these new computer-based therapies. Just delivering them whenever and wherever people are with substance use disorders. So we're kind of excited about this.
All right. And does the computer-based intervention present any unique challenges in the delivery of care?
No, we have articles that actually show that a lot of times people like it a lot better. The standard model for a lot of specialty care has been sitting in pretty unstructured groups, and a lot of people just don't like that. So we designed CBT for CBT to be really as engaging as possible. So it has these little movies with realistic characters that people get drawn into. It's really it's interactive. So we have little quizzes and kind of various kind of exercises people do, because we're really trying to teach people these skills, and we teach them as, here's something you can do to get your substance use under control or prevent relapse. But this is also a really useful skill for just being an effective human being. Sort of responding assertively and being able to tolerate craving like you tolerate strong affects and stuff. So we're really trying to. This is we built it as a fun skills training machine, and a lot of people really like it. And I think now especially with COVID, we're really seeing that treatments that people can bring into their homes or work wherever they are and use whenever really do have an advantage.
Okay. And I wanted to touch on this. As a psychiatrist, this intrigued me a bit, but I saw one of the exclusion criteria was untreated bipolar disorder or schizophrenia. Do you feel that the inclusion of these type of patients would have affected the results?
Untreated means, we really wanted people who are just stable enough to be in outpatient treatment. So, it'd be hard to initiate substance use treatment with somebody who was, actively psychotic. So I don't think we excluded anybody for that. This was our clinic is this very cool specialty addiction medicine teaching practice that's within a primary care setting. So in general, the level of serious mental illness is not very high. So, that hasn't been an issue. But incidentally, in our other trials, we did a randomized clinical trial that was done for Spanish-speaking people. And so we have a culturally adapted version of CBT for CBT. And we did that study in several, mixed mental health substance abuse clinics. And 80% of that sample had, some, Axis 1 disorder, almost every PTSD, depression, anxiety. But a third of that sample actually had severe mental illness that, was being treated with medication or whatever. And the CBT for CBT worked to reduce substance use just as effectively in that population. So, we don't, in the settings that we are, so typically, primary care, buprenorphine clinics, and substance use specialty clinics, I just, in all the years we've been doing this, I think there's just been, a handful of people that we haven't been able to take into the studies because they've just been too, psychiatrically unstable to be in an outpatient randomized trial.
Okay, and what can you say about the willingness to take part in computer-based therapy versus more traditional methods? Yeah,
I think very often, a lot of times clinicians don't want to answer. Often we kind of underscreen for substance use disorders because I think we worry that if the question is yes, what am I going to do with this, this person? Are they going to go to specialty care? How severe are they? And, I think this is one way, of many you can offer, and it's not going to be for everybody. It's not going to replace standard care, but it's one tool that clinicians and patients can use to give themselves some skills and some exposure to an evidence-based treatment that they can kind of do anywhere, anyhow. So it's pretty exciting. I think, one of the things, I'm a behavioral therapies researcher, and, one of the things I know just from listening to practice and tapes and, everything is that, clinicians often just don't have time to give people a, quote unquote dose of whatever behavioral therapy that they're doing. There's distractions, there's paperwork, there's other pressures, there's all these things that they have to do. And so in listening to tapes, there's the level of evidence-based therapies, whatever therapy you're doing, is usually not as high as it could be, certainly not as high as in the clinical trials that establish the efficacy of that approach. And so these technology-based approaches, if they really, do teach the skills as ours does, I think is just another way to reinforce what we're trying to do, to give people, a bigger, more concentrated dose of skill training or whatever whatever the treatment that we're doing. And so I think it's, a way to make treatment stronger, better, and get people, get more people to be able to be exposed to stuff like that.
Well, thank you so much for joining us on the podcast, Dr. Carroll. I really appreciate all of the insights, and this particular paper that gives us clinicians a lot to think about.
Great. Thank you so much. I really appreciate it. It was great talking to you.
This ends today's podcast. Thank you for listening to Addiction Medicine Beyond the Abstract. All of today's show links can be found in the show notes. Remember, you can preview additional abstracts at journalofaddictionmedicine.com. This program was produced by the American Society of Addiction Medicine.